straightforward case, but I'm sure you have more complex case than this one. So please, Antonio, I know you have many challenging cases, so just select the one you want to show.
Okay, thank you.
And for him also 15. And we already.
So this one I just will show you the axis and a step for the other one, which is another patient. This patient had this axis.
Wow.
So if you can see, it's very calcified, not very tortuous. And the minimum diameter here is 2.9, 3 millimeters, but the other diameter is fine. On the right side, we had a bit better, but here down there in the femoral, it's impossible to puncture. And there is this like a circular calcification. Would you go transfemoral with this anatomy? It is a 29 valve.
Look.
Of course, we can take a 29R, so we need 5 millimeters, so it's 14 French equivalent. Show you the right.
Personally, I love the transfemoral access, and I always say that when I move to femoral access, I have the feeling that I'm not doing any more interventional cardiology. So I try to do everything to do femoral, but in this case, I will not.
Fair enough. So this is the subclavian. So it was the plan B for us, because we decided to give him a chance to go transfemoral. And we said if it doesn't go, we are ready, we can switch. So we went through transfemoral puncture with a 12 French dilator. And then you can see here the 12 French dilator on a backup wire, super stiff wire. And go slow, it went through. Just I want you to imagine when we will have 12 French delivery system for TAVR, I think 99% for TAVR cases will be done transfemoral, whatever the anatomy is. Then we upsized to 14 French dilator, not sheath, just the dilator, with not much pushing, very, very carefully on fluoro. So we will be able to really dilate this femorals with the 14, but not with the 18. You can see, no, just trying to push, not very hard, so it didn't pass. So we said, okay, let's go with the 14 French sheath. If it goes, we give a try with the delivery system. Otherwise, we abort transfemoral and we go. And surprisingly, this 14 French sheath went through. So we crossed, we did the valve, and on the way back. So it was patent. This needs a stent. We didn't. This patient was good, and he's still now. I follow up with 1 year and a half. He even didn't need a stent for the iliacs. With the shockwave balloon is an alternative. We didn't have that technology at that time in Beirut. But I agree also with Thomas. You don't, especially if you're starting a program, don't push the limits because they can end with a catastrophe. So that patient, I present, it's like 35% EF, 77 retired university professor. He had a PCI mitral clip Carilion device in 2014. He had an ICD and history of many diseases, sleep apnea on CPAP, and acute and the chronic renal failure. He had the AI, with starting the LV to dilate more. So the mitral clip works very good from what we can see. And the AI is moderate to severe, but the LV starts to dilate. So it was referred for us for possible TAVR. So this was his anatomy. There is a bit of calcium here. Otherwise, it's like a pure AI with a perimeter of 88.9. Would you do this case, this TAVR? He's, of course, non-operable. He already got mitral clips. So this is the Valsalva. The coronary heights are fine. Not very horizontal. And, of course, dilated ventricle.
89, huh?
So the question?
Diameter is 89, huh? Yes,
88.9, 89.
So it's compatible with the
34
34.
at the limit, but not with like maybe 5% oversizing. But you don't have calcium. Yeah. So we said we will do it. So as you see here, we are in this range. So you can see here the first injection.
He had clips already.
Does it work? You can see three clips at that time. He got it in Frankfurt.
ICD.
You can see the Cardiology device, which is a percutaneous repair device that we don't use anymore. Yeah. He got some stents. He had an ICD.
He had everything. It's a good story of interventional cardiology.
He needs the left atrial appendage, he will be done. And so this is the case. Here we prefer to go fast pacing, as someone asked me when we go to pure AI. But it was unfortunately not possible in this patient. He was awake. We tried to keep his hemodynamics. But honestly, when I start to fast pace, he was like dropping his blood pressure to 70. So there is no more reserve. So I said, okay, I will do it without the fast pacing. So this was the original positioning. Pretty okay. So I said, okay, we continue from this. Very slow and controlled. This was a pre-deployment height. It's a bit high. So it's very important to pull back the wire. His LV is dilated, the wire is not touching anything anymore, and do very slow. And here I was really pushing.
So how much oversizing you do with AI compared to aortic stenosis?
I try to do much more oversizing, but we were limited here because already the annulus was large.
So we usually do at least 20% with a pure AI without calcification. So you get one size up with the self-expandable valves.
Exactly.
At the beginning, I used to do 15 to 20, but now just for the last one, because we don't have any other option for this patient. Absolutely. Patient really symptomatic who has contraindication to surgery. This patient with 89, if you just had 10%, we will be to 98, 99, just a little bit above the range of the 34, but I think I will do it also.
Absolutely. This was the biggest size. We used the biggest one possible. Very important to pull back the catheter very, very slowly. Otherwise, here there is honestly no calcium. I waited like 5 minutes before pulling back. I'll give it some time for the nitinol to expand. And this was the first shot. Pretty okay. We didn't see much. And this was the control. So that patient ended with the full percutaneous treatment of his structural disease and coronary as well.
Yeah, this is a whole symposium, whole meeting between mitral clip.
But he's doing fine. I mean, it's like 9 months ago. This is the echo 3 months afterwards.
Yeah.
Beautiful result. Some
Beautiful.
Just really trivial paravalvular leak. And even you can see this, his LV function is slightly better.
And as you say,
clinically
no.
I mean, with a bit oversizing, keep the nitinol. Oh, he's 77. There's not much calcium, but of course there is some thickening of the leaflets, I would presume, and I think this helps also. Balloon expandable valves are also an option with no calcium at all. Honestly, it's a bit risky, but you need to oversize aggressively as well.
Yeah.
So this is it works.
Okay.
There's some other cases, maybe the time is short. Yes.
Can we go on?
Okay. Do you want me to go for another case? Or
No,
that's fine.
I think any questions so far from the audience we have? Okay, great. These are a nice demonstration of how TAVI currently is approached from logical, procedural, intellectual, and other confounding factors that we end up with sizing, levels, depth, and so forth. They well demonstrated with the first case, and Dr. Antonio shared with us 2 different cases. One of them access challenge, and the second one is aortic regurgitation with large annulus that was treated nicely and beautifully using TAVR. To the last part of the session, Dr. Thomas will give us